Hi, this is Brian Kim. I'm going to share with you this case of a patient who came to see me. She actually found me online and had a Panoptix lens originally placed by her original doctor, and she's coming from far away actually, and she never saw well with a Panoptix lens, and that's telltale sign number one that maybe she doesn't tolerate multifocality. But the surgeon went ahead and did a second surgery and placed the lens in reverse optic capture configuration, thinking that some of her troubles was due to negative dysphotopsia. Unfortunately, this did not improve her vision. It did not help any of the symptoms. It didn't make her worse, but it didn't make her any better. And they, of course, tried surface optimization, making sure everything else was ruled out, and everything else looked fine otherwise with her other doctor. And she was just trying to adapt to the situation, never could see well. And then finally, she wanted to see what other options were out there. And as far as exchange, the surgeon wasn't really quite comfortable doing so. And so that's kind of how she ended up with me. And so, again, whenever you're doing these surgeries coming from far away, you want to rule out all pathology. Once you rule out all pathology, which can require a lot of time involvement, and then you kind of go forward and say, okay, let's work together to get you seeing better. And then, you essentially read them the riot act. I'm going to go ahead and take this lens out, replace it with a monofocal lens, but you're going to lose the benefits of multifocality. You're not going to have range of vision anymore. But this patient made it very clear to me that she didn't really care about that. She just needed that quality of vision back. And so we went ahead and did the exchange. You can see this lens is a Panoptic lens. I went ahead and made my incisions. And then I'm filling the eye with dispersive viscoelastic to coat the corneal endothelium and to stabilize anterior chamber. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And this is a 3.0 millimeter incision. And I use this incision when I do my exchanges because you want a little bit of an bigger incision when you're doing these types of cases. This is, I believe, a 27 to 25 gauge needle. And I'm going over the optic haptic junction, and I'm getting under the optic haptic junction, under the capsule with the dispersive viscoelastic. Again, this patient is in reversed optic capture configuration, and as a result, it's a little bit of a tight fit, getting that needle underneath the capsule. And as I continue to do this, I'm able to get underneath the capsule here. Unfortunately, I get some bubbles as well. I try to remove those bubbles. And then what I start to appreciate here is because it's under reverse optic capture, I can actually get under the optic rather easily here. So I'm getting underneath the optic. And I'm pushing some more dispersive viscoelastic right there in the subincisional area. And then away from me, you can see I'm getting underneath the optic here some more as well. And so that's the benefit of reverse optic capture. The optic is actually above the anterior capsule, so I'm able to go underneath it and really push everything back and push the posterior capsule back as well, any potential vitreous. And then I'm going to go ahead and lift the optic with the scissors, grasp the optic with the IOL holder, cutting little by little, turning the teeth of the scissors sideways so it's not more vertical, it's actually sideways. And this helps me see what I'm doing, and it makes sure that the cutting edge of the scissor that's towards the posterior capsule is not going to be too far back. And now that you have two pieces, I'm going to have much more control in being able to take these pieces out. I'm trying to get underneath the optic haptic junction, pushing some more dispersive viscoelastic to tease the capsule off the haptic. And as anyone knows with these lenses, the Alcon lenses, the terminal bulb is the hardest part to deal with because it has that rounded bulb. You want to be very careful making sure you don't cause any capsular bag and zonular traction when you're taking these lenses out. So I'm holding the lens with my right hand, and with the forceps closed, the teeth closed, I'm just trying to peel off the capsule from the lens, the terminal bulb there. And once you do that, I'm going ahead and grab the cut edge of the optic, protect the cornea with the other forceps, and the lens comes out nicely. So again, you want to grab it in a way that you know that the haptic is going to collapse. So I grabbed that cut edge, pulled it out, and as you pull it out, I had the other forceps protecting the corneal endothelium, and then you saw that the haptic optic just kind of collapsed and then came out nice and easy there. Now this side, unfortunately, the haptic is really trapped and incarcerated within the capsular bag, and that's the only other issue when you have patients coming from other places, needing exchanges. You know, you didn't do the original surgery and you don't know how thoroughly they clean the bag. In those cases, you're really worried that the lens is incarcerated within the bag. And so oftentimes, if this happens, don't break the zonules or the capsule bag. Just go ahead and amputate the haptic from the optic, which I did here. And then very carefully go ahead and pull that optic out, protect the corneal endothelium with the other forceps. And with these lenses, of course, they're very gummy and malleable. And now I have a little bit more room to work with, but as I try to pull it out, you can see the capsular bag is really incarcerated around the haptic. And as I try to pull it, I'm able to pull it some, but you can see there's still quite a bit of stress on the zonules. And so you have to ask yourself, is it really worth it? You know, you keep pulling, maybe you're going to cause an area of zonular dialysis. And, you know, you just kind of have to weigh the pros and cons of all that. Of course, if you're really aggressive, you can actually rip a hole in the posterior capsule as well. And so at this point, I just decide I'm going to amputate the haptic. And just remember, I just cut the more proximal edge of the haptic and see how I do with that. And then I go ahead and pull these pieces out. And I decide I'm going to just leave the rest of that in there. And now we're going to go ahead and put the monofocal lens into the ciliary sulcus. You see I pushed some cohesive viscoelastic to fill the sulcus. And this is the 3-piece lens. It's going to go into the ciliary sulcus. You've seen me do this many times in my primary cataract surgeries. Make sure the optic comes out planar, the trailing haptic is outside of the eye, and then just dial that trailing haptic into the sulcus. And then ultimately, I'm going to perform an optic capture configuration. Go ahead and place a 10-0 nylon suture to close the main incision, making sure that nothing will want to come forward, vitreous or anything like that. Anytime you're dealing with these complicated cases, I like to place a 10-0 nylon suture. You never know, you might encounter vitreous, so I go ahead and put that suture in just as a precaution. Removing the viscoelastic from the anterior chamber. Make sure I maintain the optic capture configuration. And then I push BSS and come out with the INA handpiece. Once I make sure all the viscoelastic has been removed, go ahead and tie off the suture. I go ahead and hydrate my incisions, thinking I'm good. But as I check the wound, I notice something. Oh, I have vitreous. So again, you're dealing with these cases, open posterior capsule, patient's been yagged, they had a reverse optic capture of the Panoptix. A lot of things has been done to this eye to see if the patient can tolerate that multifocality. But unfortunately, they did a YAG, And whenever you have that situation occur, you try to do the best you can, but nonetheless, there is obviously vitreous now to the wound. Very carefully amputating anything that's external now. Again, another reason why I always put in a tendon suture, and it was obviously a good idea that I put that tendon suture now, because after I finish the case, I have good confidence that I'm not going to have vitreous come to the wound because I've already sutured the wound. So this is going to be bimanual anterior vitrectomy through 2 limbal incisions, and I'm just going to make sure that the vitreous in the anterior chamber and on the wound is removed. Obviously, this is in optic capture configuration. Again, the lens is in the sulcus, and then the optic has been buttonholed through the capsular rhexis. And because it's a nice stable rhexis, the optic capture should be nice and solid. So that vitreous is really the vitreous that came forward during the exchange part of the case. And so by amputating this vitreous, you shouldn't really have more and more vitreous coming forward because there's no direct passageway for the vitreous to come forward. That passageway has been effectively closed off with the optic capture using the lens. So you can see here, I'm just spending a lot of time making sure I'm doing a good vitrectomy, removing the vitreous, anything that might be adherent and incarcerated within the wound over the main incision. And once I've done that, I go ahead and hydrate the incisions, check the wound one more time. There's absolutely nothing now. It's nice and dry, no vitreous whatsoever. And that's the end of the case. So this patient, again, had a Panoptix lens, never saw well. The patient was rather frustrated, had a reverse optic capture done by the surgeon, didn't help the patient, and then had a YAG capsulotomy, didn't help the patient. And so this patient came to see me. She, again, I reiterated that she'd lose her multifocality. She admitted that she never saw well after the surgery. We did all the extensive testing from front to back, making sure everything was good, and everything looked healthy. And so I went ahead and did the exchange. The patient was so happy after the surgery. She was in tears, and now the weird aberrations is gone. She does admit now afterward that she sees this shadow on the outside edge of the vision, but not bad enough to do anything about. And so I felt like this was the best way to handle her situation. Let's just deal with the poor quality of vision from the multifocality. As far as the negative dysphotopsia, again, I think it would have been more complicated to go in there, putting the lens in the bag, and then reverse optic capturing this lens. Regardless, this patient was very happy. She felt like she got her life back and her vision back and her career back. And so this was a very gratifying case. Again, anytime you're dealing with a patient coming from far away, you did not do the surgery. You don't know how easy the lens is going to come out because you haven't necessarily cleaned out the bag like you normally do on this patient because someone else did it. Obviously, one of the haptics is really stuck and it wouldn't come out. It just went ahead and amputated it. Whenever patients come from far away, you want to do your due diligence, but also set realistic expectations. And fortunately, this patient did well. So I hope this was helpful to you, and I thank you for your attention.